Welcome back to Pharmacology with Dr. Sokolow. So this is another module on drugs that affect the cholinergic nervous system. And the first one we are going to talk about are the cholinesterase inhibitors. So cholinesterase, if you remember, is the enzyme that breaks down acetylcholine once it binds to the receptor. So it just breaks down acetylcholine. And so therefore, if you inhibit that enzyme, you inhibit the degradation of acetylcholine, and then you're going to have more acetylcholine available to activate the receptors. So you're going to intensify the transmission at all junction, not just, the neuromuscular junction, but also you're going to activate the cholinergic receptor in the central nervous system. So you're going to have an activation of both the nicotinic and the muscarinic receptor because you just have more acetylcholine floating around. And if you remember, acetylcholine can bind to both receptor, the nicotinic and the muscarinic receptor. So that's why they are called indirect acting cholinomimetic, because it's not from the direct action of acetylcholine on the receptor, but it's from by preventing the degradation of acetylcholine, you have more acetylcholine available at the synapse. So that's why they are called indirect acting cholinomimetics. And what are those agents? You have two types of agents. You have the reversible agent and then the irreversible agent. So reversible, that means, you inhibit the enzyme and then that inhibition is reversible and, it's not continuous. You have hydropophonium, which is used for the treatment of myasthenia gravis, which is a disorder of the skeletal muscle. The Nepizel, I'm not going to ask you to memorize it for now because we'll see it next quarter when we see the drug for Alzheimer's disease. But that's one of the few drugs that are used for the treatment of the symptom of Alzheimer's disease. And then you have the irreversible agent. So that means bind to the enzyme irreversibly, and you have to wait for more enzyme to be synthesized. And this is actually used locally, like it's a topical agent. It's an eye drop that are used for the treatment of glaucoma. So ecothiopate is the irreversible agent. Now, the anticholinesterase agent, there are other agents, but they don't have any pharmacological use. But these are the pesticide and the nerve gas that I mentioned when I talk about atropine and the atropine. So malathion and parathion are pesticides that were used in the past and that could cause, symptom of the central nervous system because of this anticholinesterase effect. And then suman and sarin, you may have heard those names. They are, chemical weapon. Unfortunately, they are still in use. And, as you can see here, they are like article from the Syria wars, and they were used on civilian in Syria. And so that's why I said that military who are going to countries where they use chemical weapon, they will carry an atropine just to prevent, poisoning from those nerve gas. Now, anticholinergic drug, another one, are neuromuscular blocking agents. So we talked about anticholinergic drug, or more specifically antimuscarinic drug, that act on smooth muscle cell. Now we are going to talk about the one that are acting specifically at the neuromuscular junction, because you remember those nicotinic receptors are on the other receptor located at the neuromuscular junction. So this figure shows the excitation contraction coupling of a skeletal muscle, and again, this you've probably seen that in your physiology class. So here you have your motor neuron, and when it's activated, where there is a signal to contract, it will release acetylcholine at the neuromuscular junction. and the release of acetylcholine, by binding to the receptor at the neuromuscular junction, to those nicotinic receptor, are going to induce a depolarization of the motor end plate and ultimately generate a muscle action potential, which will lead to the release of calcium, and the calcium would bind to the actin and the myosin on the muscle fibers and will just induce the contraction. And so this is the cycle of that action potential at the neuromuscular junction. So you see the neuromuscular junction is basically localized at the middle of a muscle fiber. And so when you have an action potential at the motor end plate, so you have depolarization. So you see here, you have the depolarization. So the charge that were positive, negative, now it's negative, positive. And this depolarization has to be transmitted along the muscle fiber, not just at the muscular junction. So you're going to have the depolarization of the end plate will trigger a wave of depolarization along the muscle fibers. And you see here, so now you have those positive charge along the muscle fiber, not just at the neuromuscular junction. And of course, this is tension, and then you have a repolarization that follows the unbinding of acetylcholine from the end plate nicotinic receptors, and then you go to the resting state again. I'm showing this because we're going to see drugs that are acting on this depolarization mechanism. So neuromuscular blocking agents, there are two types. The non-depolarizing agent that are called competitive agonists. So if you remember from pharmacodynamic, the difference between competitive versus non-competitive antagonists. If you don't, I'm asking you to go back to those slides. So they are competitive antagonists, the coronium, rocuronium. You're going to see them in acute care setting. So they are actually rapidly inactivated by the acetylcholinesterase that is going to hydrolyze them, and so their effect only lasts 20 to 40 minutes. But they are used for the induced relaxation for surgical procedure, and during COVID this is widely used because they are used for intubation procedure. So how do they work? They block the nicotinic receptor at the neuromuscular junction because they are antagonists. So they are just going to bind to the receptor, the nicotinic receptor, prevent the action of acetylcholine. And if you prevent the action of acetylcholine, then you just inhibit the contraction and induce a relaxation. Now you have the other class of agent that are the depolarizing agent, and so those, they are partial agonists. So again, partial agonists have some intrinsic activity and as an antagonist effect, so they can bind to the receptor and then induce a depolarization. And then because they stay there, because they're also, so at first they're going to induce a depolarization, and then because they stay there and they also have an antagonist effect, it's going to prevent, acetylcholine to bind, but also this, they're going to prevent the repolarization cycle. So it's going to depolarize, and because it depolarized and prevent the repolarization, you have actually a relaxation that lasts. So it prevents from another contraction, and so therefore you have a relaxation. So the persistent depolarization make the muscle fiber resistant to further stimulation by acetylcholine and just stays in that state of relaxation. And succinylcholine, which is a depolarization agent, is a preferred agent because it has a very short acting, short half-life, 4 to 6 minutes. So you can reverse the paralysis, just doesn't last for too long. And again, this is used for surgical procedure and intubation. And the last drug that we are going to use, we're going to see, is the botulinum toxin or Botox. So this, and then the one that is used in clinical, so Botox is the botulinum toxin A, which is produced by Clostridium botulinum, which is a bacteria that can cause botulism, which is, cause if you eat a food that is contaminated by that bacteria. That is not common, but that can happen if you develop botulinism. And so basically Botox that is used in cosmetology, or now it's used, has some clinical indication, just does the same thing as the toxin that is produced by that bacteria. So how does that work? It acts presynaptically and inhibit the release of acetylcholine from the presynaptic terminal. So if you don't have acetylcholine that is released, it's going to induce a temporarily paralysis, because you don't have a contraction. So that means you have a relaxation, your muscle doesn't contract, and that effect can last weeks or several months. So this is really like the relaxation of the skeletal muscle. And so there are two dosing depending if it's for cosmetic use or wrinkle phase. You see here it's an intramuscular injection, 50 to 100 units, and then the one that is used and approved for different medical conditions, it's a higher dose, 100 to 200 units. It's approved for strabism, for people who have primary axillary hyperhidrosis, short-term people who sweat a lot. Cervical dystonia, prevention of chronic migraine, overactive bladder with a neurologic condition, lower and upper limb spasticity, hyperfunctional wrinkle phase. This is not the cosmetologic version of it. And also, under investigation for other indications. Now, this is, still a toxin. So people who are giving Botox, well, first of all, it's an intramuscular injection, and they have to know exactly where to inject, at the neuromuscular junction. They have to be well trained to do this, because actually it can cause botulism, and that's why there is a black box warning. So a black box warning, it's a statement that is issued by the FDA to tell the risk with a medication, like a severe adverse reaction. And if you click on the link, you can see like the list of adverse effects in people who has botulism, through food ingestion. They suffer from respiratory symptoms, because basically the diaphragm muscle is relaxed, it doesn't contract, and they have problem breathing. So this can happen with injection of Botox if it's not appropriately given. And also on the FDA label, you could see exactly what are the site of injection based on the indication. So, I just wish that all the ladies who are taking Botox to have, bigger lips, that they would also consider getting a COVID vaccine, which I consider safer than getting a Botox injection. And then preventive migraine therapy. So here you see all the injections. So this is really like for patient who has severe migraine. It's not just, if you get a headache from studying too much pharmacology, that you would get Botox injection, but it's approved for, patients who have 15 days per month with headache, and that those headaches last for 4 hours a day or longer. Because the safety and the effectiveness is still not being established for the prophylaxis of episodic migraine, in several placebo-controlled studies. But It has the indication on the on the data label. So then again, if you go and click here, you will see all the indication that are for Botox. And this concludes the chapter of cholinergic drug. We still have to go to adrenergic drug, and that would be the last module of this autonomic nervous system. And thank you for listening, and see you in the next module.